Furst was the first Carl Pearson Professor of Medicine at the University of California, Los Angeles, and received his MD from Johns Hopkins University and 2 fellowships, rheumatology and clinical pharmacology. Dr. Furst has been on a number of national committees concerned with the rheumatic therapies. He recently was co-leader of the ACR recommendations for the use of non-biologic and biologic therapies in RA, and is a master of the ACR. Dr. Furst has published more than 650 articles and 15 books, including more than 220 research articles. Dr. Furst's area of research interests include clinical pharmacology of anti-rheumatic drugs and biologics, and the pathophysiology and treatment of systemic sclerosis. On a personal note, I just want to say that Dr. Furst has been so helpful to our community, just like Andrew mentioned. He has not hesitated when I've asked him to come aboard and talk about pain in scleroderma. He talked about GI involvement in scleroderma, lung involvement, updates on clinical trials and the treatments. And then I think this is our 4th COVID update. And I send him the messages letting him know that there are a lot of concerns out there. And without hesitation, he continues to be helpful to us and bring us these great, very detailed talks that he puts a lot of effort in to make sure that you have the most recent data so you can make informed decisions on your own. So we thank you and Elaine more than we can express, Dr. Furst, for everything that you do for us. And we want to thank you. So without further ado, I'd like to let Dr. Furst take the floor.
So we have a fair amount we want to talk about today. I want to talk about COVID-19, of course, and ignore all that stuff at the bottom. Next slide, please. Those are my disclosures. I work with a lot of companies to get my research done. Next slide, please. I don't have any conflict of interest with respect to this. What I want to do is I want to answer 14 questions which patients have asked me. And then at the end, I want to leave time to ask any other questions you may have. The best way to do that, by the way, is in the chat box. I think you can also raise your hand, but there are enough people that it might be hard and we might miss somebody. Next slide, please. First question. I have scleroderma. What can I expect if I get COVID-19? Next slide. So this is a trial that we did from the USTAR database in Europe and the US. And it looked at about 180 patients. Who's speaking?
Please make sure everybody is muted.
Looked at about 180 patients, and about 2/3 of them were on immunosuppressives. They had all sorts of kinds of scleroderma with lung involvement in 60%, etc. And what you see here is kind of a nice outlook.
So he could work at another school in Arizona.
Someone is speaking. I'm sorry. About 72% of people recovered without any difficulty at all. But about 24 of them, 24%, were either hospitalized or required intubation or even died. And 12% died. So it would be very important to know what are the sorts of things that predicted problems. One, not unexpectedly, age. The older you are, the more trouble you have if you're going to get this disease. Another is whether you have a lot of complications, diabetes, hypertension. Tina, can you go back, please? We got to get this organized, Tina. So the most important thing was that if you had renal disease, that really predicted problems. Next slide, please. We don't have other looks at this in scleroderma, But if you look at a large database, it was 17 million people. And what they did was they looked at all patients who had RA or lupus or psoriatic arthritis. And they did a nice job trying to figure out, get what to do with comorbidities and things of that sort. One of the problems was that they didn't look at what kind of medications people were using, how active their disease was. But what it says is that if you have an autoimmune disease, you have about a 20% possibility of getting much more severe disease. So what does that say? It says that if you have scleroderma or other autoimmune diseases, you really have to be careful. In this study, it was a 19% increase in the possibility of dying. Next slide. Well, what about the Delta variant? This is a big deal, and we all know that. This is a study, just came out in June, where they looked at what happened, what was going on. And what they found was two things. First of all, the Delta variant has some mutations on the spike, which makes it easier for them to get into the cells. And so a lot more get in, and therefore you can detect it earlier. So relative to the Alpha variant, that's the one we're used to, you can detect it in 4 days instead of 6. But what's really important is the concentration of the virus in the nose and the body, 1,200 times increased concentration. Next slide. To give you a feel for this, that's about 1,000 dots compared to the 1. So what does that mean? Well, it means that if someone has the Delta variant and they breathe in and out, they're going to put out 1,000 times as many viruses. If they cough, 1,000 times as many viruses. If they have it, 1,000 times more of the viruses inside them. So this thing is really difficult. And for patients with autoimmune diseases, and we'll talk about this later, it's very important to be vaccinated and to be very careful going outside. California says, well, no worries outside. I recommend strongly that you wear your masks inside and outside. Why? When you wear a mask, it protects you from others and you protect others 70%. If you use a double mask, it's 90%. So if you're well masked, you're well protected, not 100%, but well protected. So wear that mask inside and outside. And of course, get vaccinated. We'll talk much more about that. Next slide. One thing that we have to be aware of is the kids. And the question that's been asked of me is, should my kids go back to in-person school? Next slide. This is a pretty good study. What they did is they looked at people in North Carolina or Wisconsin or Norway or Israel. And in Norway, North Carolina, and Wisconsin, the kids wore masks. That's called mitigation, and they separated in school. And the incidence of infections was well under 1%. You can see the various percentages in the various places. And the transmission was less than 1%, less than 1 in 10,000. But in Israel, there was a place where they didn't do that. They went back to school, no masks. Transmission, 13 to 16%. So what does that mean? Well, yeah, the kids should go back to school, but you need to ask, if you have children, whether the kids will be masked in the school and whether there's social distancing. Very important to keep you and your family safe. Next slide. What about if you had COVID, can I get it again? Next slide. Well, this looks at reinfection, but not with the Delta. And if you look at this, you see the rate of it in primary infection, in other words, getting the infection in this area was 5%. At the same time, in those patients who had the COVID, the rate of reinfection was 0.31%. So about less than 1% of the rate. Okay, so reinfection was very rare. All bets are off with COVID Delta because we're talking 1,000 times as infectious. So we can expect, and I'll show you more data, but we can expect that 15 to 20% of people who have been vaccinated will get reinfected. That reinfection rate, however, will be importantly different because nearly 90% of those reinfections will be mild. You'll get a cold. Only a very few will get sick. So reinfection rate in the Alpha variant, less than 1%. Reinfection with the Delta variant, and this is an estimate, it isn't based on data, is 20%, but mostly mild. What does that say? Get vaccinated, wear a mask. Next slide. What about long COVID? How often does it occur? What happens? Is there something you can do about it? Next slide. Well, how does long COVID work? It's probably related to three things. The acute infection, and it'll be longer if treatment is inadequate, if there are complications, if there's some problem that occurs during the COVID, and if there are a lot of comorbidities, as well as whether there are side effects from the drugs. So if the disease is more complicated or your body is not set up to fight it very well, that is a more probability of getting long COVID. And if during COVID you get a secondary infection, if you have this cytokine storm, which is very rare, that means you're more likely to have long COVID. And if there are psychological issues, anxiety, depression, worry about family, prolonged hospitalizations, all of those can result in long COVID. So we kind of understand what's going on. Psychological issues, inflammatory issues, complicating issues, all make for long COVID. Next slide. So this looked at a group of patients, 143 of them, who got long COVID. They were followed up at 2 months. And those who got the long COVID, you see on the left, only 13% were totally free of symptoms. And all the others had at least one or sometimes 3 other symptoms. Well, what were those symptoms? And on the right, you see during the acute phase, most commonly, and in this case, 80% of the time, there was fatigue, 70% shortness of breath, 50% joint pain, and of course, a lot of cough. multiple other problems, including things like vertigo, diffuse muscle aches, diarrhea. Well, if these people got post-COVID, long COVID, and what you see is that the most common symptom in long COVID on the right there is fatigue. And that occurred in 55%. Shortness of breath, 50%. Joint aches, 25%. And then many of the others. So with long COVID, fatigue, shortness of breath, joint pain are the most common symptoms, with darn near anything else happening occasionally. Next slide. There was another study which looked at a much larger group of patients over a longer period. So this is 1,700 patients over 6 months. And in those patients, the most common long COVID was weakness, kind of nearly fatigue. And then poor sleep, worry, anxiety, and in 13%, there was a small amount of decrease in kidney function. It stayed normal, but it was a little bit down. So if you've got long COVID, and I sure hope you don't, but if you do, make sure your doctor checks your kidneys now and then. So what in this study predicted long COVID? 1, baseline anxiety and depression. 2, baseline or during the COVID episode, a lot of fatigue or weakness. 3, lung problems. And that means, the HRCT of the lung or the efficiency of your body taking in oxygen was decreased. So if you have bad disease and if you have a lot of anxiety, depression, weakness, and lung involvement, that predisposes you to long COVID. Next slide. So what can you do about it? And there is something you can do about it. This was in 900 patients in the UK who had the long COVID. And they were revaccinated when they had the long COVID with Moderna, Pfizer, AstraZeneca. And here's what happened. 57% of them improved. Get another vaccination, most of the time you'll improve. They don't all necessarily go away, but you improve. And 20% get a little worse. So what can you do? You revaccinate. Next slide. That was a registration study. Basically, they looked back and asked people what was going on. This is a smaller study, but it looked forward. It took patients, and some of them got vaccinated and others didn't. It was not randomized. It was whatever they happened to do. And they looked for 8 months after, at which point they received either the Pfizer or the AstraZeneca. And they asked what happened 1 month after the second vaccination. Okay, here's what happened. 23% completely resolved their symptoms compared to 15% in the non-vaccinated. Basically, more than 50% increase in resolution of symptoms. At the same time, far fewer of the patients worsened if they got vaccination than if they didn't. So basically, a better outcome, 50% increased probability, and much less likelihood of worsening. Okay. Was there any difference between Pfizer and AstraZeneca? The answer is no. Was it 2 vaccinations for each? I don't know. They didn't say. What would I do? And I'll say this again, if you have long COVID, get revaccinated with one shot of Moderna or Pfizer. Is this totally data dependent? I mean, data derived? No, it is not. There are hints of this, but it is a hint. Next slide. Another question. Are there good tests to tell me if I'm infected by COVID-19? And could I have COVID-19 and not test positive? Next slide. There are a lot of tests out there. 13 that are out there now look at antibody to the spike protein, but 8 of them look at the nucleocapsid. And while these numbers seem to indicate they're about equal, in fact, there's a lower sensitivity to the nucleocapsid. So if you're going to get an antibody test, get it, make sure that the antibodies against the spike protein. If you get a negative antibody test and it was against the nucleocapsid, that's the inside of the virus, all bets are off. So it doesn't mean that if your antibody test is negative, that in fact you aren't immune. It just says maybe they did the wrong test. So make sure you know what antibody is being tested. Next slide. And there are all these rapid tests. These are the 15 to 60-minute results. Well, this looked at 30,000 tests. Okay. And the standard was the one with the where they stick it up the nose and do all that. It's a very good test. But they looked at the rapid tests and look at the problems. With the lateral flow, it doesn't matter what it means. The lateral flow, it was only positive if you have COVID-19, 66% of the time. And with the ELISA, 84% of the time. So if you're going to get a rapid test, it's pretty good if you use the CLIA. Don't try and remember chemiluminescent immunoassay. Forget that. But ask for the CLIA. The others just aren't as good. Next slide. So how can I tell if I'm protected? Next slide. It's a neat picture on the left, isn't it? Those are antibodies attacking the virus. Now, this is somewhat complicated, but it isn't as complicated as it looks. In the right upper hand corner, in the A, when you're looking at it in the left upper hand corner, what it shows is that you can see the antibody in the blood over time after the vaccination. You can see, you don't see it 9 days after the vaccination or after having COVID for that matter. But by 26 to 35 days after the infection or the vaccination, all of the tests were positive. And if you look at on the right next to it, all those little dots, what it says is by the time you're at 20 days, 100% of the time, you can see the antibody. But early days, the first couple of weeks, all bets are off. At 1 week, maybe 50% of the time, is it correct? So what does it say? It tells us that the antibody tests are pretty good, but you have to wait a while after your vaccination or after you got your infection to know if your body mounted a response. You get vaccination, you have to wait 3 weeks before you do the test to know if your body did respond. And if you got a negative, you wait another week. Okay, so you can tell if you got a response, but you got to wait 4 weeks after COVID-19 symptoms have resolved, or 4 weeks after the second shot, or 4 weeks if you're taking the one shot vaccination. Okay. Next slide. So what about vaccines? Let's talk about them. Next slide. I know the vaccines work, but are they all equally effective? Next slide. We have to take a little segue here. We have to learn a little bit about the immune system. Many of the immune active cells are lymphocytes, a kind of white cell, but there's more than one kind of lymphocyte. There are B lymphocytes, and they produce antibodies, and there are T lymphocytes. They don't produce antibodies, but they turn on B cells to produce antibodies. And the T cells have a long memory, and they're sitting there ready to respond. That's why the vaccines, the better ones mostly, are the way they are. The first shot activates B cells. The second shot gets the T cells ready to respond the next time the body is exposed. Okay. Next slide. So here are the different ones. And here's the efficacy, how good they are. The mRNAs, and some of them are not in this country, of course, but Pfizer and Moderna, 95%. Look at the J&J. It's a virus. It's not the mRNA. What they do is they take a virus, they kill it, and then they use, they produce antibodies against the whole virus. For the mRNA, it's just a tiny little fragment. There's no way, by the way, in either case can you get infected from them. But the mRNA has been used for years and years for Ebola, for things of that sort. So we know it works. And in this case, it works very well. J&J, not so much. There's an AstraZeneca product made in India. It's kept in India, which is only 80%. The Chinese products are all over the map. Some of them only 50%, others 80%. So the currently authorized ones vary, but the mRNA is probably the most efficacious. Next slide. Did the vaccine work on the variants? A big question nowadays. Next slide. That's a little complicated slide, but it's important, and it's worth walking your way through. This is a group of patients who are vaccinated with either Pfizer or AstraZeneca. And they wait to see if any of them responded to the antibodies for the Alpha variant or the Delta variant, or if over time any of these people who were vaccinated got the infection. And if they got it, did they get it to the Alpha variant or the Delta variant? And you can see that for the Pfizer, they got the Alpha variant and the Delta variant had about equal efficacy. This was after the first dose. You look over to the left of these. The first three are after the first dose. The second three are after the second dose. And after the first dose, the Pfizer was about equal, but only about 40 to 50%. The AstraZeneca was not nearly as effective against the Delta. So for the Alpha, it was 50%. For the Delta, it was 30%. Now, after the second dose, remember what happens after the second dose? Those T cells come charging out there and they produce a vigorous response. They show up after the second dose. And you can see that the Pfizer was 94% effective against the Alpha variant and 88% against the Delta variant. So not quite as good, but pretty darn good. If you look at the AstraZeneca, well, overall, not quite as good, right? The Alpha variant only 75%, and the Delta variant 67%. But certainly, both cause a response to both variants. Bottom line, the vaccine, at least these two, give you protection not only against the original, but reasonable, not perfect, protection against the Delta. You got to look at these numbers carefully. What it says is that if you had the Pfizer, 12% of the time, you're not protected against the Delta. And if you had the AstraZeneca, 30% of the time, you're not protected. So what does that mean? It means you better mask and you better keep away from others when you're indoors. That's social distancing. Otherwise, you put yourself at greater risk. If you mask, you get 90% protection against the 12% with the Pfizer. So your chances using the Pfizer and masking, couple of percent. For the AstraZeneca, not as much, but still only about a 10% probability if you mask and you've been vaccinated. Next slide. So if I have scleroderma or another autoimmune disease, will the vaccine work? Next slide. So there's a small study. The patients had various kinds of autoimmune diseases. You see RA, something called Behçet's, lupus, psoriasis, other things. In that other, there may have been a scleroderma patient. We don't know. And when you look, day 7 after the second vaccination, 87% of the patients got adequate response. So if you have a rheumatic disease, it's highly likely, not quite as good as healthy controls, see about a 10% difference, but you got an 87% probability that your vaccine will be effective. So the presence of the disease itself does not significantly decrease the efficacy. It's not 100%, but it's pretty good, 87%. Next slide. So a little segue, because you're going to hear a lot about this. You've heard from many people, well, I hope not many people, but from some people, that the vaccine will make you sterile and will cause problems in your pregnancy. Let's look at that. The question is, if I'm pregnant, will the vaccine cause problems for the embryo? Will it cause bad result if I'm pregnant to the kid? Next slide. So this is an 800 odd pregnancies, and they compared the results to a general population. It's on the left there. And you see that abortions occurred in 13% of the cases, miscarriages compared to 18% if they had COVID from the general population. In other words, it doesn't cause more difficulties to the baby than in the general population. Does it cause more difficulties overall? Well, yes. If you have not got COVID and you got pregnant, about 5% of the time, there'll be miscarriages or abortions. So it does increase it, but it increases it equally in vaccinated and unvaccinated. And what kind of problems occur if you get vaccinated? If you look at this, you can see right down the line, it's just like every other person who got vaccinated. Lots of pain at the site, tiredness, achiness, joint pains, but no different than if you weren't pregnant. So pregnancy doesn't hurt the kid. Pregnancy doesn't make the COVID-19 vaccination any worse. Next slide. I didn't say that right. What I meant was vaccination, if you're pregnant, doesn't cause a problem with the kid. So what about breastfeeding? Next slide. So this looked at antibodies in the breast milk after vaccination. And if you look at 4 weeks after the vaccination, about 88% of the time, you'll find antibodies in breast milk. Okay, so what does that mean? Well, for the first about 60 days or 30 days, the baby doesn't produce any acids. And so the breast milk proteins get across and protect the baby. In fact, that's true for everything, right? That's why people breastfeed. They get those proteins across, proteins are absorbed and protect the baby. Once about 60 days have elapsed, the baby begins to produce acids. So they break down some of the proteins. So after 60 days, the breast milk gives nutrients, lots of them, obviously, but they aren't as protective with proteins like vaccinations. But at about 60 days, the baby begins to produce its own antibody responses. Isn't nature wonderful? So before the baby's able to respond, antibodies, including COVID-19 antibodies, get absorbed and protect the baby. After that time, the baby begins to produce its own antibodies. The problem, of course, is we can't vaccinate the babies at this age against COVID-19. So they are at more risk of COVID-19, and you have to be careful with them, but you're careful anyway. Next slide. What about the sterility? Will the vaccine make me sterile? Next slide. What they did here was they looked at people who had difficulty getting pregnant. There's 143 people, and they did embryo transplants. The story with the vaccine is that theoretically, through some similar proteins and stuff, it can prevent the embryo from being implanted and prevent potentially the embryo from growing. That was the theory. That was the fear. That was what was put in the newspapers. But in fact, here's what happened. You look at a group of vaccinated, that's the orange, yellow, infected, not vaccinated, but infected, the gray, and not infected. And the patient's implantation, and you can tell that by pregnancy tests, were the same. whether vaccinated, infected, or not infected. And the baby grew at the same rate. No differences among these. In fact, if anything, the vaccinated grew a little faster, but certainly not slower. So it says that the COVID-19 vaccination does not prevent pregnancy and does not sterilize the mother. Next slide. What about the sperm? Here's a study in sperm, and we don't have to go through it in great detail, but look at the sperm mobility. And the sperm mobility was 58% before vaccination. And that's about normal. And then 2 months after the second vaccination, it was essentially the same number. Statistically different, but actually supposedly more mobility. But practically speaking, those are the same. mRNA vaccination did not affect the sperm. Again, did not cause sterility. And we've got the data. Next slide. What will happen to my scleroderma or my autoimmune disease if I get vaccinated? Next slide. This looks at induction of diseases after vaccination. And you can see here the various vaccines on the left, the diseases in the middle, and the frequency on the right. Let's look at the bottom first. Vaccination against things like yellow fever and rabies can cause these autoimmune kind of things in between 2 and 6 patients every 1 million vaccinations. Extraordinarily rare. So what about with connective tissue diseases? So the vaccines are on the left, the kind of diseases that seem to appear in the middle, and something about its frequency. So let's look at RA. In the whole world's literature, only 16 cases were found that seemed to result in RA after these vaccines. For lupus, 25, and that's from 1974. 25 cases in 43 years. Same thing is true for vasculitis or inflammation of the muscles. Extraordinarily rare. You never say never, but it's probably in the range of 1 or 2 per million. Next slide. Well, would you go back one if you can, Tina, there. So what does this say about flaring the disease? Well, it doesn't answer this specifically because the data aren't there specifically. But looking at this, one can say that it's possible that it could flare the disease, but the frequency of the flare is going to be somewhere in the range of 2 to 3 to 4 per million patients. So effectively, you can say it doesn't flare the disease. Next slide. Now, what about my medications? Will my medications interfere with the vaccination? And if so, is there something I can do? Next slide. So we're going to take a step back and look to see if the medications can make the disease COVID-19 worse. So this looked at RA, and it was about 2,700 patients. And it looked at 3 outcomes: hospitalization, hospitalization requiring oxygen, and death. And what you can see, Someone's
والله العظيم
someone's
كانوا صغيرين.
needs to mute. Yosra, please you mute. What you can see here is that the percentage of patients who got sick or died on rituximab were much higher than things like Enbrel or tocilizumab. Likewise, there was some increase in patients who got very sick and even died if they were on something like Xeljanz or another JAK inhibitor like Rinvoq. And finally, there was a trend towards increased problems with severity of the disease if you were on Orencia or abatacept. The ones to watch out for severity, rituximab, let's use the words Xeljanz and Orencia, not with the other biologics. Next slide. Another difficult slide, but really important. You can see on the left in autoinflammatory diseases, some of them listed there, RA, vasculitis, lupus, but scleroderma fits in between lupus and vasculitis and RA somewhere. But overall, the antibody response, if you had an autoimmune disease, was 15% less than control. 100% response in this group where they defined response as 100% versus 86%. Now look, there are some of them, vasculitis, where it's much less, but overall, about 15% lesser response. So how much of that is due to the medications? And that's on the right. That orange dotted line is adequate response. And this is looking at antibodies. And we can go through this carefully. Let's do so. If you're on GC, steroids, they didn't say what dose, but it's a very high dose, I'm guessing 20 milligrams or more, but I don't know that. If you were on glucocorticoids, your ability to respond was cut down by about 40%. And assuming that's high dose. If you're on less than 10 milligrams, that's much more likely to be something on the order of 5 or 10%. What about methotrexate? Decreased response by 11%. So look at the other end. What about mycophenolate? Very marked decrease in response, 39% instead of 100%. Rituximab, that's anti-CD20. Again, much lower response. So that if you're on these drugs, your response to vaccination is likely to be significantly less. There are a whole bunch in the middle, things like Enbrel, tocilizumab, which does just fine. You see that one that says anti-IL-6. It's well above the 100% mark. But if you add methotrexate to it, it cuts it down to about 95%. In fact, with these biologics, if you're on the biologic plus the methotrexate, in nearly all cases, it cuts down the response to the vaccine significantly. Okay. Now, this talks about vaccination, but you got to realize that with vaccination, we have an easy way around, right? You have to stop it 2 or 3 weeks before and not start it again till about 2 or 3 weeks after the second vaccination. However, if you've got an illness, it's pretty clear that if you're on a drug, the body is not responding completely normally, and more so for some drugs than others. A little bit with steroids, a very little bit with methotrexate, a significant amount with Cellcept, a significant amount with rituximab, and essentially no decreased response by tocilizumab or Actemra. So what can you do about this? Next slide. You can get vaccinated. So what happens when you're vaccinated? You never get something for nothing. What's the side effect? And when I say vaccinated, I mean revaccinated, having been vaccinated. If you haven't been vaccinated, as I say, you stop it for 2 weeks or 3 weeks, not rituximab, that's different. But with most of the others, 2 to 3 weeks off, and then wait till 2 to 3 weeks after the vaccination, and you'll be all right. If you want a second vaccination, you have to think about side effects. That is a third shot. Most vaccine takes 2 shots. This would be a revaccination. And so you have to worry a little bit if that's going to increase problems from side effects. Well, we already talked about pregnancy, and sterilization does not seem to have an effect. A very rare case after J&J results in decreased platelets. Again, the number is 0.3%, I believe. For the AstraZeneca, well, they get blood clots. 1 case per 100,000. Really not much. On the other hand, if you're giving it to younger women, you should be a little careful. That being not you, but your doctor. If it comes to the Russian or the Chinese, there is a very rare possibility of HIV occurring. There are a whole bunch of others, but we don't know about them. From the American point of view, we're okay, except maybe a little bit with clotting and bleeding, and only a few of them. I want to give you a comparison. If you look at the top, this is anaphylaxis to penicillin. And the incidence of anaphylaxis to penicillin is about 2 to 3 per million patients given penicillin. And penicillin is 10 times as frequent in terms of these serious side effects as the COVID-19. Bottom line, yes, but extremely rare. And you've heard me say this a million times. You never get something for nothing. So on the one hand, protecting against COVID-19 in 90% or 80% of cases. On the other, negative, on the order of 1/10 as often as penicillin. So pretty safe, pretty much in favor of getting the vaccine. Next slide. Well, what can I do about this problem with the drugs preventing a normal response? Next slide. You revaccinate. Now, this is a fascinating study, because what they did is they took some patients and gave them something, a viral one, twice. In others, they had given them a viral and they gave them an mRNA. And in other cases, they had given them an mRNA and they gave them another mRNA. This gets back to this T cell issue. Because what happens is, if you change the vaccination, your body's response says, wait, there's something foreign here. I better really respond. So here are the results. Here, you're looking at the antibodies, the antibody to the spike, or what are called neutralizing antibodies. You don't have to get into the details. And what you can see is that if you were given the viral vaccine twice, the antibody response was okay. But if you switch from virus to mRNA, it really kicked it up. And if you use the mRNA both times, very good. Next slide. Now, looking at the T cell response. Remember, we talked about that. So if you go from virus and repeat the vaccination with virus, not so great. Not bad, but not so great. If you go from virus to mRNA, in other words, cross over, you get a much better response. Of course, the mRNAs were good both times. And this results in a response when your T cell is reacting to the spike. If it's reacting in a more non-specific way called SEB, they all worked. Bottom line, if you've had an mRNA for the revaccination, crossover. If you had a viral, crossover. So you go from something like J&J to Moderna. If you've had Moderna, probably give Moderna again. mRNA, revaccinate with mRNA. Virus, revaccinate with non-virus. You can see the results. So there is something you can do if you're on these drugs which suppress the response. You can stimulate the immune system, your immune system, to respond to give you better protection. Next slide. So I know I've taken a little extra time, but I really think it's worth it. These are the questions I answered. I'm going to let you look at them again, because now I want to leave it open for you to ask about these or about others. So I answered these questions. Next slide. And I finished off by answering these questions. Okay, now, what are some of the other questions? Tina?
I'm going to unshare my screen, Dr. Furst. Thank you. Okay, I'm going to go to my chat box first. What about Moderna? I don't know what this question is, Mary. What about Moderna, same as Pfizer? And I do believe that Dr. Furst answered the difference between the two vaccines, if that's what you were asking. Do you agree, Dr. Furst?
Well, let me answer the question so you know. They're both mRNA vaccines. They're not exactly the same, but they seem to cause essentially equivalent responses. Now look, you can't say for sure if you don't have the actual data, but thus far, they are really equivalent in how much they seem to cause responses. In their side effects, no, there's not a big difference in side effects, and in their efficacy with background meds, etc. So one to the other. If the question basically is, if I have Moderna and I want to get revaccinated, should I go to Pfizer or vice versa? Can't answer that. I don't think it's going to make a big difference. I think the critical thing is get revaccinated. You might ask, well, now, how do I do that? If I go into someone and say, I've had it, but I want to get it again, they're very likely to say wrong, buzzard breath. I'm sorry, wrong, you can't do it. So I didn't say this because I never want you to tell an untruth. But someone might say, well, I haven't been sure about it and I want to get vaccinated, and kind of skirt about previous. That may be the only way, because it's going to be months before we get the answers, but you've already seen the answers. It's just that it may take some time for the official wheels to grind. Next question.
This person says, if I got 2 J&J vaccines suggested by Dr. Furst, should I ever get an mRNA booster?
So you heard that the J&J was about 66% effective. But you also heard that if you revaccinate, you end up with turning those T cells on to get a really better response. So the question is, if I've gotten a good response and I'm on one of these drugs, should I do it again? And if I did it again, should I do it with an mRNA? We don't have answers to that, but on a clinical basis, if you're on mycophenolate or you've been on rituximab, one thing you can do is look at your antibodies. If your antibodies are good, you don't need it again. It's a different question coming up, but you don't need it again. If they're not, then if you're going to want to get protection, you probably should cross over. Okay. Am I talking about database? Absolutely not. I don't have any data on this. I do have the logic and the understanding that I have about viruses. I'm sorry, vaccinations. So I think sometimes we have to go beyond the data. And on a clinical basis, that's what I would do.
Thank you. When will we be able to get the 3rd dose in US?
Well, we just answered that one. I think the studies are no doubt underway,
Okay.
but until they are approved by the FDA, could well be 6 months to a year. So you have to work your way around it. Now, I'm not telling you how to do that, of course. I wouldn't do that.
Thank you. I'm not sure if I understand this. Virus to mRNA revax, 1 or 2 injections? Question mark.
Okay. Yeah. So in the study, what they did was they gave, say, the J&J, which is single, and then they crossed over to the mRNA, which was 2. When they did mRNA to mRNA, they did 2 each time. If you're going from mRNA to viral, you do the 2, and then you do the 1 from the viral. Does that answer the question? The person who put that, please say yes or no in the chat box.
Okay. And I think you basically answered this, that yes, you are recommending booster shots to your patients, and more specifically to the ones that are on the drugs that were on your slide that were more compromising to them not getting full benefit from the vaccination, correct?
Yes. Now, there's another question that kind of is sitting back there, and that is, so how long does the vaccination last? Is everybody gonna need a booster? We have data that is very clear that the percentage of protection decreases at 6 months by about 6%. So at 6 months, there's still pretty good protection, but it is beginning to drift off. How long will it last? We actually have no idea. What do I actually think? I think that we're going to need shots just like we do for flu. Are we going to need 2 shots each time? Remember, this is data free. I don't have the data. But if we think about it, the second shot has primed the T cells to respond. Those T cells continue to be ready to respond. So in my view, it's highly likely that when we do get a booster on a yearly basis, we'll only need 1 shot, because all we're doing is reactivating the ready to act T cells.
Thank you. What about air travel?
Wouldn't it be nice? No, sorry. If I were a patient with an autoimmune disease, I think until the Delta's taken care of, I would keep away from air travel. Why? Because that darn bug is so infectious. And unfortunately, the airlines are not keeping their distance. They are saying you should mask, and that's good. But I guess, it's never a cut and dried thing, is it? I guess if you are really healthy, I'm going to pick rheumatoid arthritis. A rheumatoid arthritis patient or a scleroderma patient who's been really doing well and has been on no medication and has been vaccinated and feels they really have to go. I'm not just going for a vacation, but my mother got sick. In that situation, carefully, you could do it. But if you were a patient with scleroderma on oxygen, no, not worth a 3 or 4% chance.
Thank you. I was diagnosed with pulmonary fibrosis in 2018, but it's not progressive, and I'm not on CellCept or any other scleroderma meds. My question is, what are the chances that contracting COVID would activate or trigger the pulmonary fibrosis to begin to be progressive?
So you saw the data that exists. You can say, generally speaking, that it's unlikely that it will progress. Can you guarantee it will not progress? No. If you get COVID-19, are you more likely to get really sick? Yes. So it's always a balance. But if you're doing really well, I don't know what this person's pulmonary function tests are. I don't know what the actual HRCT looks like. I don't know what her 6-minute walking test is. I don't know what other diseases she has. We all know already from today, this is complicated. But if a person is basically healthy and is not on medications, even though they have scleroderma, that puts them in the range of everyone else. So if you think about everyone else, infection, 5%, 10%, reinfection, 1%, 2%. I don't know if that's helpful, but she asked, or he asked, a very complicated question just then.
Thank you, Dr. Furst. I think you've already answered this, but it's a little different. And what about air travel where a complete vaccine and or negative test is required before boarding the plane, Maui?
Okay. Well, I've answered the question in general. Going on vacations, probably not what I would do in the presence of Delta. It's not Delta Airlines, sorry, Delta variant. Obviously, if you feel you have to go and you've been fully vaccinated and you can document it, more importantly to yourself than them, and you use double masks, that's about as safe as you're going to get them out.
Thank you. I think a lot of people have something similar to Ilana's comment here. I'm on azathioprine. I didn't stop my meds for the first 2. Would I need to stop them for the 3rd? And most likely many, whether it's azathioprine or others, didn't, because we didn't have some of the data we have now. So what's your thought on that?
So I assume she's talking about what I will call the revaccination.
Yes.
And I would treat that as if it were the first vaccination. And so you stop the drug for a couple of weeks before, you keep off it, and you restart only 4 weeks after, 3 to 4 weeks after the second or final of those. And if it's a single one, same thing. 2 weeks, 3 weeks before, except retux, different story. 2, 3 weeks before, and wait 4 weeks after. 3 or 4. Okay.
Thank you. I think you answered this on your slide. If I was on CELSIP at the time of vaccines and received 2 Moderna vaccines, what is the efficacy of the vaccine?
Probably decreased quite significantly to the range of 50% or less of the original. How do I find out? If you've had the vaccination at least 4 weeks ago, get an antibody test against the spike protein, not the nucleocapsid. If you've got a good response, I'm not sure what a good response is, but if you've got a good response, you're likely pretty well protected.
Thank you. If somebody, this is my own question on that, if somebody does get that checked and finds that they're not, do you think that not waiting for the booster, would somebody be able to go back to their doctors and say, I need another vaccine because it was so low? That's just a curiosity.
Yes. Well, first, remember what I said. The antibody should be against the spike protein,
Correct.
not the nucleocapsid. So let's say you did the spike protein, it was negative. I think the first thing I would do is do it again. Let's say it was negative twice. Then depends on your doctor. Personally, I would say it's compared to the trade-off that it's reasonable to go ahead and get a third or a single revaccination.
Thank you. Okay, what if a person started the vaccination process, example, getting the first dose of Moderna, but did not get the second dose? How should the person proceed in getting vaccinated? Should she wait until next year or start the vaccination process again immediately?
Yesterday would be good enough.
Okay.
By the way, look, I do have room in my practice, not a lot, for people who have these kinds of questions or other ones. So you can get to see me, and there's some other really good docs around, so that you can get some answers from people.
Okay. Laura also said that she didn't, the answer didn't come out correctly. She said, I had 2 J&J. Now, do you suggest 2 mRNA?
No, we're lucky. We can get an antibody. If the antibody is positive, you don't need another one. If the antibody is negative to the spike times 2, you might need another one. And I would not go to the same one you were using before. I'd use a crossover based on the data you saw.
Okay, thank you. My friends got Guillain-Barre and he was vaccinated and wore a mask. How can we prevent getting Guillain-Barre? Is there anything we can do?
Okay, so we're going a bit afield here. This is Guillain-Barre, and it's a neurological test. And it turns out that there is a vaccine. So I don't want to get into, all the other possible vaccines, but there is a vaccine and there is a way to treat. So I go back to your neurologist and ask for it.
Thank you. She says, sorry to repeat, but to clarify for a third vaccine after 2 mRNA should go to viral or third mRNA.
According to the data you saw, it looked like repeating the mRNA is the best route to go.
Thank you. If my daughter is on rituximab, Celsep, prednisone, warfarin, and got Pfizer, what booster should she get? She has 3 overlapping conditions.
So I'm not sure it's all additive, but it's pretty clear that her response is not likely to be very good. But I keep saying this, we have a way to test. If she has a poor antibody level to the spike, then she's going to need to be fully revaccinated. The way I would do it is see what your antibody response is, assuming you're getting a T cell the second time. If there's any question, do a second dose.
Thank you. If on my Fortix, should I stop the meds 2 to 3 weeks before or after revaccination?
Yes.
Thank you. If I stopped mycophenolate before vaccination period and after, back on it now, would I still have only 39% efficacy?
No. Your body has now responded. Those cells are ready. If your mycophenolate suppresses those cells, you will have a lesser response. But the body's incredible. It may suppress your autoimmune disease and not suppress your response to COVID-19. Can you assume that to be true? No, you cannot. What should you do? Revaccinate, use masks, be darn careful.
Thank you. Let's see. Do you need a doctor's order to get an antibody test?
Well, in a lot of places, the answer is no. You go into a place that says doing antibody tests. I believe, not sure, that this is being covered by the government to try and get people to understand what's going on with their vaccination. But sometimes if you can't find it by a freebie, you have to get your doctor's permission or an order. It shouldn't be very hard to do.
Thank you. If your doctor says to be revaccinated, how do you go about getting another shot? Can doctor prescribe, or do you just do the half truth and schedule it?
I think that if you can get it with an order, that's definitely what I would do. So I'd ask him to do it. I'd go down to the nearest vaccination site. In some places now, the doctor's offices we're trying to get that done in our clinic, but the amount of paperwork is remarkable. So if you can get a doctor's order, do so.
Thank you. I'm going back to the ones that were sent to you originally, and I'm trying to weed through them because you definitely answered a lot of them, but this is one I don't think we completely covered. Would having low IgG factors make one either 1, more susceptible to a bad case if one got COVID, or 2, make it less likely one would develop a strong immune response to the Moderna or Pfizer vaccines?
Very good question, actually. It turns out that with rituximab, one of the dangers is the rituximab decreases the IgG. In fact, that's one of the things that lets doctors know that maybe we can't continue, because once the IgG gets very low, you can get other infections, not just viral infection. So if you have a low IgG, are you likely to have a lesser response? We go back to the data you saw that if you were on rituximab, you had a higher probability of a bad outcome from COVID-19. The way and the reason was because the IgG was probably low, or at least the cells that produce the IgG was low. So if your IgG is a result of rituximab, you are at greater risk. If your low IgG is due to an intrinsic disease, then for some people, the treatment is treating with IgG, gets into a totally different area. Just to keep straight, if your IgG is low, your response is likely to be less good dependent on which cells produce that IgG. Again, you can get an antibody test.
Thank you. And well said, by the way. Does
Thank you.
Dr. Furst recommend those who took Cytoxan in the past and are on another immunosuppressant now take another COVID shot, not necessarily a booster, but a third shot like some cancer patients are doing? What are his thoughts on additional shots?
So how long does the effect of Cytoxan last after you stop? For most of the things about which we're speaking now, it's gone between 6 months and a year. There are some that last longer, but it doesn't relate to this. So if you are on Cytoxan, I'm going to say 5 years ago, it's as if you never were on.
Mhm.
So now we're talking about whatever drug you're on now and its effect on vaccine response or on COVID. Okay.
Thank you. I think even though you did talk about this, it's worth maybe repeating. How can we prevent getting Delta variant besides being vaccinated? Is wearing a mask and washing your hands enough? Because my friend's son got the Delta variant and he took all precautions and was vaccinated. Just wondering if there's anything else we can do.
Well, let me give a little bit of a more thorough answer. The vaccine is only somewhere between 85-ish percent effective. That means 15% of the time you're not protected. If you add a double masking, that gives you a 96 or 97% probability that you're protected. But even under those circumstances, 3% of the time, you're luck of the draw or phase of the moon or something awful or some comorbidity. So you're never 100% protected. I wish it were so, but it won't be so. And so you can only do what you can do. You have to be careful. You don't want to go ahead. You don't want to go ahead and just go out into the bar scene and have a good time. You're just going to have to be careful.
Thank you. Does taking Bactrim affect taking third vax?
Good question. In a very general way, the question that's being asked is, if I want to get a third vaccination, does being on an antibiotic prevent the response or make it more dangerous in any way? And the answer is, in a very general way, talking about other vaccines. The answer is no. Bactrim, okay. Penicillin, okay. Keflex, okay. But you never know if you're going to get a right reaction to the Bactrim. If you're tolerating the Bactrim, you can get the third vaccination without having to stop.
Thank you. I have scleroderma and I've had both COVID-19 vaccinations. Following my second shot, a very painful ulcer opened up. It became a serious PG infection. It is progressively worse. Did the vaccine cause it? Should I avoid a booster shot?
Another very good question. In patients with scleroderma, if you get an ulcer, all of you who have had ulcers know it can be a real problem. What happened, I'm assuming in this case, is that your body's response to the vaccine was very vigorous, and it caused inflammation in that area and resulted in the damage to the tissues that you see as an ulcer. So, the ulcer per se was a result of not the vaccine, but the body's response to the vaccine. The treatment is going to be just like any other ulcer. It can be difficult, it can be long, but it will heal. Eventually, there's things we can do.
Okay.
What about getting a second shot? Wow, I probably wouldn't. Why do I say that? Just so you know. If you got that kind of response the first time, why aren't you going to get the same kind of response the second time? You will. Consequently, not a good idea.
Thank you. Going back to the one question, she says, I want to clarify if on CellCept at time of both doses, I should get antibody test, and if numbers are low, should I go off meds and start whole process again, or just go off meds and get a booster?
The most conservative way would be get off meds and do both shots. The probably adequate way is get off in one shot. Are there data? No. I'm going along from the understanding of what's going on. So, you know, we can't be sure, but I think if you're really, really concerned, get off, take both shots. By the way, you know, I've been pretending that that third shot has no side effects. Not true. You could get the same kind of side effects or effects that you got after, or anyone gets after a vaccine. So don't assume the third shot is going to be a no-brainer. Okay.
Thank you. Let's see. Yeah, you answered this one too. Hold on, let me go through this one more time. Okay, received my vaccines at the beginning of the year before I knew that patients taking mycophenolate should stop taking the meds a few days before and after receiving the vaccine. I had absolutely no reaction to either of the Moderna shots. Pulmonologist suggested I get third shot and make it Pfizer, and also said I should not stop taking mycophenolate before the shot. Rheumatologist said I should wait for the CDC recommendations for the immunosuppressed patients.
We've actually kind of answered it, haven't we?
Yeah.
That is antibody titer, and if low, get the shot. If you're going to get the shot, stop your meds 2 weeks before, 4 weeks after.
Okay. Let's see. I've been diagnosed with systemic scleroderma and pulmonary fibrosis since 2013. I've been prescribed CellCept, but discontinued when I got my second Pfizer vaccine for about 4 months, vaccine about 4 months ago. My rheumatologist is in Tijuana and have not been able to get my refills for a while. My symptoms are currently stable. My question is this. I currently work as an RN COVID-19 vaccinator at a small indoor site with poor ventilation and not enough social distancing. We average about 100 to 300 patients a day, sometimes up to 500. I double mask and wear a face shield. Also, I was told that I will soon be doing swab testing. With the Delta variant on the rise, am I at risk for getting COVID working as a vaccinator or doing swab testing? I've also been taking vitamins such as zinc, vitamin C, and vitamin D for extra protection. Thank you in advance.
Okay. So we have to dissect this one. The effect of the mycophenolate on a vaccine after 4 months off is very low. So you're only seeing the effect of the underlying disease. The underlying disease does not seem to affect vaccination. Step 2. Because I have an underlying disease and I am seeing a lot of people who are likely to be infected, am I likely to be infected? The answer is yes. And there's no guarantee that you'll do well. In fact, there are reasonable probability of you doing very poorly. Bottom line, not a good place for you to work. Period. You need to be, what about restarting mycophenolate? The effect of the mycophenolate will last somewhere in the range of 3 to 6 months. So you have to recheck what's happening in your disease to see when and if you need more mycophenolate.
Thank you. If I got Moderna for the first vaccination, both shots, and get a third, doesn't matter if I get Pfizer, or should I stick with Moderna?
No particular data saying one or the other. If, from my point of view, it's a flip of a coin. If you want to follow the logic of the study that I showed you, you should go to Pfizer if you are on Moderna. But there are no data saying that it makes a difference.
Thank you. Does IVIG affect when the vaccine should be given?
Yes. Now you're going to ask how much. The answer is it's quite a long time. It has to be probably at least 8 weeks.
Wow. Thank you. Does the ingredients in the vaccine cross the placenta?
Really a good question. I think I should start out by saying, I don't know all the ingredients in the vaccine. I think one can say with a great deal of confidence that there's something there to keep it from getting too acid or basic. There's something there to keep it from getting infected or breaking down. And there may be something there to protect it against everything else. For the first two, if it is very unlikely to cross the placenta. What'll happen for most of these things is it gets into the placenta, but the placenta is built to take care of that kind of stuff. So it's very unlikely to cross over. The third, if it's a protein that's there, it's possible that that could get across the placenta. Do we have data? It may exist somewhere, but I don't know it. I think one can say the probability of it getting across the placenta is very small because, as I say, the placenta is built to try and take care of toxins.
Well said. Thank you. That was actually my last question.
Great. Well, folks, I think I really appreciate your questions. Good questions. I hope this has been helpful to you. I believe, but I'm not positive, that Tina can give you copies of the slides.
Yes.
If you decide to give lectures on this, please give credit to my wife who made most of the slides. Okay.
Absolutely. Make sure of it. We're always appreciative of Elaine's help. And again, Dr. Furst, thank you so much for coming aboard today and providing this very timely talk. As I said, I knew that we would get a lot of people registering for this, and we got a lot of people outside of California, by the way, all throughout the United States and even some out of the country. And so I'm so glad that we can be of service and have people come and visit with us today, and that you all get to see your fellow scleroderma warriors, and you all get to talk with Dr. Furst, which always does such a great job breaking it down on layman terms so we can all understand the necessary precautions that we need to take and the steps for the future with COVID-19. So again, thank you, Dr. Furst. And